Hyperthyroidism is when you have an increased level of circulating thyroid hormone. This would increase the basal metabolic rate and also increase the sympathetic nervous system activity. Very high yield to note. Board examiners like you to know how it increases the basal metabolic rate. It increases synthesis of sodium potassium ATPase, whereas the increased sympathetic nervous system activity is due to expression of beta-1 adrenergic receptors. Again, both of these are high yield, sodium potassium ATPase and beta-1 adrenergic receptors. Now, the clinical features are going to be based on an increased BMR. So the way I think about this, the body goes into overdrive. You get weight loss despite increased appetite, heat intolerance and sweating. Again, you're burning a lot of ATP, which is going to generate heat. The patients get tachycardic with increased cardiac output. Again, they've got that increased sympathetic nervous system activity. Arrhythmias, for example, AFib, can also occur, especially in the elderly. They get tremor, anxiety, insomnia, heightened emotions, staring gaze with lid lag, diarrhea with malabsorption. Again, the idea here is that the gut's sort of moving a little bit faster as well. Patients with hyperthyroidism can develop oligomenorrhea. They get bone resorption with hypercalcemia. This could eventually lead to osteoporosis, and they get decreased muscle mass with weakness. Finally, the patients can get hypocholesterolemia. This is particularly high yield. The examiners like you to know that you get hypocholesterolemia with hyperthyroidism and hyperglycemia. And the idea here is that the thyroid hormone causes both gluconeogenesis and glycogenolysis, resulting in extra sugar in the blood. The most common cause of hyperthyroidism is Graves' disease. This is where you have an IgG antibody that stimulates the TSH receptor. When you stimulate the TSH receptor, you increase the production of thyroid hormone, and you also increase the release of thyroid hormone. So two things are going to occur: increased production plus increased release. This is the most common cause of hyperthyroidism, as I've already stated, and it classically occurs in women of childbearing age. Again, this is the classic demographic for an autoimmune disease. Clinically, the patients are going to have hyperthyroidism. Again, you have increased production and secretion of thyroid hormone. They get a diffuse goiter. As this antibody is stimulating the TSH receptor, that's going to cause massive hyperplasia and hypertrophy of the thyroid diffusely, resulting in a diffusely enlarged thyroid, and the word goiter refers to an enlarged thyroid. And they get exophthalmos and pretibial myxedema. Now, this is very important to note and very high yield. This is not due to the hyperthyroidism. It is due to the fact that the patients have an antibody that stimulates the TSH receptor. So the idea here is that the fibroblasts behind the eye, as well as the fibroblasts over the shin, they have TSH receptors. And so in response to this antibody, they actually begin to secrete excess glycosaminoglycans, which then results in exophthalmos because the eye gets pushed forward, and a pretibial myxedema. Edema here refers to the fact that it looks like there's swelling of the tissue, but the word mix refers to the fact that it's not due to water, but instead it's due to glycosaminoglycans, or a mixoidy substance. And clinically, they classically describe this as a dough-like appearance, so that when you press over the shin, you actually can feel a dough-like consistency to the tissue. Now, of course, these patients are going to be producing excess thyroid hormone, so there will be both an increase in total and free T4. The TSH will go down, and that's because the free T4 will downregulate thyroid-releasing hormone receptors in the anterior pituitary. Recall that the anterior pituitary secretes thyroid-stimulating hormone, but only in response to thyroid-releasing hormone that comes from the hypothalamus. And so what T4 does is that it downregulates these receptors so that the anterior pituitary will then no longer be able to receive this signal and therefore will produce less TSH. The patients will also have hypocholesterolemia. I've already explained that. And they'll have an increased serum glucose. I've already explained that as well. The treatment for Graves' disease includes beta blockers. Again, you're trying to block the effects on the sympathetic nervous system. Thiomide is another treatment. This is a drug that has the ability to block peroxidase. Let's go back and remind ourselves, if this is the follicular cell of the thyroid, remember that the cell takes tyrosine and it converts tyrosine into thyroglobulin, and then the thyroglobulin is pushed off into the follicular lumen. This is where the colloid would be. And then at the same time, the cell takes iodide from the blood and brings it into the cell and then crosses it over to the follicular lumen where it undergoes oxidation and becomes I2. Remember that the thyroglobulin and the I2 are then added together in a step called organification, and that's going to result in thyroglobulin with monoiodotyrosine and diiodotyrosine. And of course, the mono and the di will be coupled together, and that's going to then produce thyroglobulin with T3 when mono and di are coupled together, or T4 when the di and di are coupled together. Now, important to note that all of these steps here, the oxidation, the organification, and the coupling, these are all catalyzed by peroxidase. And so if you block peroxidase, obviously you're going to block the ability to produce thyroid hormone. And so that's how thioamide works. Another possibility would be to use radioiodine to ablate the thyroid. The idea here is if you give radioiodine, of course, that would be taken up by the follicular cells of the thyroid, which would then result in destruction of the thyroid cells because of the radioactivity, and so you would ablate or destroy the thyroid gland. The thyroid storm is the feared complication of Graves' disease. This is when you have excess catecholamines and massive hormone, usually due to some sort of stress like surgery or childbirth. The patients can present with arrhythmia, hyperthermia, and vomiting with a hypovolemic shock, and this is treated with PTU, beta blockers, and steroids. Recall from pharmacology, particularly high yield, that PTU inhibits peroxidase-mediated oxidation, organification, and coupling, as I've already explained. All three of those steps are also going to be inhibited by PTU. In addition, PTU inhibits the peripheral conversion of T4 to T3. Recall that the major hormone released by the thyroid gland is T4, and then T4 gets converted peripherally to T3, which is the more active form. And so PTU will also block the peripheral conversion of T4 to T3.